1 out of 10 physicians have a vulnerable plug and even plug rupture. And if a physician has diabetes or hypertension, his risk is 1 to 5. So the chance that a physician has a vulnerable plug is very high, particularly if he has additional risk factors which are promoting the coronary arteriosclerosis. In my situation, I am convinced at the moment that I have not a vulnerable plug because a recent test of CRP showed a normal level. On the other side, if I had a vulnerable plug and no symptoms, I would clearly lower my risk by taking aspirin, statins, beta-blocking agents, and ACE inhibitors. I think these 4 drugs are at the moment at the top what we want to do. And if there are any symptoms, any reductions in exercise tests, then I really would suggest that I undergo an angiography and see whether or not a coronary hotspot can be detected. And as you know, I am in favor of intravascular ultrasound at the moment, and if I have available, I would combine it with thermography. These 2 techniques are the ideal ones in order to really see if plug erosion or plug rupture is present, so hotspots. And if a lesion is then in the proximal part of a LAD, then I clearly would take into account implanting a stent, drug-eluting stent, of course. If it is a lesion more distally, I would be in favor of a more conservative way. That's, I think, the modern thinking to handle vulnerable plugs. But of course, we physicians are not out of risk. And I may, at this position and this situation, point to Ronnie Campbell, who died just over the age of 50 some years ago, and last year Jeff Isner, who also died suddenly, and both were physicians, both were cardiologists, both were scientists. So we have also to look for ourselves, not only for the patient screening. Everyone in the field of cardiology, and not only there, has also to be a pioneer in looking for a screening for himself and thereby doing what he is suggesting to the patient.